So thank you, Grace, for inviting me to speak today. I always enjoy talking to patients. That's kind of why I do this. My lung cancer journey is a good example of living with lung cancer and the value of being an engaged patient. I was first diagnosed with stage 3A non-small cell lung cancer in May 2011. I never smoked anything except a salmon. Okay, thank you. After a month's delay to treat obstructive pneumonia, I had concurrent chemo and radiation. My primary tumor and lymph nodes all responded. 2 months later, a PET scan found a new hot spot on my collarbone. A biopsy confirmed my cancer had progressed. Since I had severe radiation pneumonitis, my oncologist recommended a break from treatment. And in the next 3 months, I grew a 3-inch mass on my collarbone. However, I wasn't just a recipient of care. The information I learned in the online lung cancer community enabled me to become an interactive participant in my care. From other e-patients, I learned to ask for my data, including radiology and pathology reports. I also learned more extensive molecular testing was available through the Lung Cancer Mutation Consortium protocol, and I arranged to have my slides sent to the University of Colorado for a 10-oncogene panel. Unfortunately, all those tests were negative, so I had more chemo, followed by more radiation. And a new scan showed all the known tumors were gone or dead, but I now had 2 new tumors in my other lung. It seems like within 2 months of ending treatment, I was progressing. My oncologist told me I would be on chemo for the rest of my life. But here's where the tone of my story changes. An online patient, thank you, Craig and PA, told me I fit the profile of patients who had the ROS1 rearrangement. Relatively young, adenocarcinoma, never smoker, and negative for EGFR, ALK, KRAS. He sent me a journal article of the early trial results. I showed it to my doctors in Seattle, but they hadn't heard of it. So after my second progression, I contacted the University of Colorado again and learned they had recently developed a ROS1 test. I gave them permission to use my remaining slides. When I learned my cancer was ROS1 positive, I enrolled in the crizotinib trial in Colorado. Thanks to precision medicine and the online lung cancer community, I've had no evidence disease for 33 months and counting. I'm not cured, but I'm living well with lung cancer. Evidence-based medicine is necessary for my survival. The 1990s model of evidence-based medicine has 3 components: relevant scientific evidence, good clinical judgment by the healthcare provider, and knowledge of the patient's values and preferences. Healthcare providers can study and train to develop good clinical judgment. Providers and patients can read and attend conferences like this to obtain new relevant scientific evidence. Unfortunately, the patient values and preferences is very often left out, and it's essential to shared decision-making and absolutely critical to help patients survive a deadly disease like lung cancer. So I propose the evidence-based medicine of 2.0. We patients need providers who know the current guidelines and standards of care. They facilitate us getting second opinions and clinical trial participation. They consult experts familiar with the new treatments. They help patients navigate the healthcare system. They explain care options so patients can understand. They help patients obtain survivorship supports, and they solicit and honor the patient values and preferences. Now, that's a tall order, especially because the healthcare system is a very complicated place, especially for lung cancer patients. Despite ongoing efforts, fax systems and CDs are the only way to transfer data between facilities. Lung cancer patients usually have multiple specialists and facilities to deal with. Outside of my initial hospitalization, I have dealt with 2 medical oncologists, radiation oncologist, pulmonologist, infectious disease specialist, cognitive neurologist, clinical trial coordinator, numerous nurses, 2 healthcare systems in 2 different states, 2 2 medical record systems, a contracting nursing system for my PICC line, and an oxygen vendor. When I was preparing for potential pneumonectomy, which is removal of a lung, I had 16 medical appointments in 15 days. No one coordinated any of these things for me. All of that fell to me as the patient. For most lung cancer patients going through treatment, this is pretty overwhelming. So what can we do? You become an e-patient. E-patients are not just people who go online to get information. E-patients are anyone who is equipped, engaged, empowered, or enabled, and these patients can become equal partners in their care. Just by attending this conference, you're being an e-patient. In the online lung cancer community, I found patients with my type of lung cancer getting the exact same treatment who understood exactly what I was feeling and experiencing. They answered the questions I didn't think to answer at the doctor's appointment or to ask at the doctor's appointment when I was still in shock over my diagnosis. They suggested ways to cope with side effects at home. They prodded me to ask doctors about issues I hadn't thought were important. And they were available in the wee hours when the fear was overwhelming. The information I learned online enabled me to become a participant in my care. From other e-patients, I learned about asking for my data, asking for reports, learning about treatment options and typical side effects. I also learned about the new molecular and genomic testing, things that my doctors in my home clinic did not know about. I learned how to find and become a participant in clinical trials, which is what's keeping me alive. And I found hope. If I had not had access to other e-patients, I would be dead now. Preliminary studies indicate patient engagement and shared decision-making can increase patient satisfaction and outcomes and reduce healthcare costs. Activated patients are less likely to be readmitted to the hospital within 30 days of being discharged, less likely to have poor care coordination across providers, and are less likely to lose confidence in their healthcare system. Now, I know most of you have gone online, so I don't need to show you what an online forum looks like, but I'm going to show you this picture for a reason. See that little picture over in the far right corner? That's a squanch. That's where my online name comes from. It's the mascot of my dorm floor at MIT. So whenever you think of squanch, think of a little yellow Hershey's Kiss. Lung cancer social media on Twitter, or LCSM, which you've heard us talk about, is a collaboration across all of the stakeholders in the lung cancer community. As you can see from the wrong picture, this is data that Dr. Matt Katz presented at ASCO this year. The LCSM community is a good balance of patients, which are in blue, doctors, which are in green, healthcare organizations, which are in purple, and others. By tracking LCSM on Twitter, which means you just search on the hashtag LCSM, you can learn about new research findings, advocacy opportunities, patient questions, clinical trials, support services, and facts about lung cancer. Thanks to research and new treatments, more lung cancer patients are surviving longer and learning to live with lung cancer as a chronic illness. Unfortunately, this disease still kills more Americans every year than the other top 3 cancers combined and gets less funding. Why is that? Are lung cancer patients not worth saving? Well, the answer becomes clearer when you Google lung cancer people. No throngs of ribbon supporters, few smiling survivors. You see damaged lungs, death, and cigarettes. Lung cancer has an image problem. The breast cancer community has done a good job of changing the image of their disease, and lung cancer must do the same. Now that more lung cancer patients are surviving, like us, we need to band together and use our voices to raise awareness of lung cancer, make people aware of the other risk factors, such as radon gas, air pollution, and workplace exposure. We need to increase funding for research and support other patients. By doing this, we can help fight this stigma. Patients can also partner with research and advocates. Engaged patients can make a difference. Last year, advocates were instrumental in obtaining Medicare coverage for lung cancer screening. A group of lung cancer survivors helped change the National Comprehensive Cancer Network guidelines for treatment for metastatic lung cancer. Patients and advocates have been discussing clinical trials and conferences, ways to help identify patient needs, and effective communication methods. In the past month, a research study began at the University of Colorado Lung Cancer Spore to work with family members of deceased lung cancer patients to help get their archived tissue out of community hospitals and into biobanks so that researchers could access it. I got this program started as the Spore advocate at the University of Colorado. Sharing what I've learned and advocating for others gives me a sense of purpose and satisfaction, even when I'm not feeling so hot from treatment side effects. So here's a few quick survival hints for e-patients. Become your own best advocate or recruit one, like your spouse. Find a doctor who specializes in lung cancer. Ask about genomic tumor testing. Get a second opinion. Learn your treatment options. Insist on shared decision-making with your doctor. Consider a clinical trial. Accept yourself. Having a bad day is okay. Make peace with uncertainty. Have the conversation with loved ones now while you feel good. Let them know what's important to you. And share what you've learned and experienced with other patients. Thank you for this opportunity to talk, and I want to acknowledge all of the patients and caregivers who've shared their information with me, and for Craig and PA who couldn't be here for help with the slides.